things that influence cough in IPF are the acid reflux, and it's more prevalent than reported in IPF patients, 21 to 94%. Worldwide, it's more like 8 to 33% in the normal population. In fact, there's several studies where they've done 24-hour pH monitoring. Some of you may have had where they put that wonderful wire down your stomach for 24 hours. 94% of the patients had evidence of abnormal reflux. And the caveat here is not everybody who has bad reflux has symptoms. Up to 48 to 50% of people who have bad reflux have no symptoms. They don't feel any acid reflux. I've had plenty of people, I don't have GERD, I feel fine. And we'll do the test. Yeah, you do. That's why that's part of the cough. Or when my ENT doctor looks down, they'll say, yeah, they've got inflammation. I see the reflux coming up. It's reflux. So it's definitely something that should be considered. And it's more, even though it's more common, like I said, it's the classic heartburn symptoms are present in less than half of the IPF patients with actually known GERD. So we really want to look for silent GERD. Antacid therapy will decrease acid reflux, but unfortunately doesn't always have an effect on the cough. And I think that's in part because the cough is multifactorial. The cough isn't just one thing. And that's what makes cough so difficult. Very often cough is multiple things. And so I say, I know you have this, keep that treatment going. We're just going to pick off each thing and fix each thing as we come to it until we sort of get to the end of that line of fixing everything. Multiple studies have shown that sleep apnea is a big deal in patients with IPF. In one study, it was 62% of patients had moderate to severe sleep apnea. I know there are lots of people with sleep apnea that don't like to wear their machines. And the machines do a really good job of decorating bookshelves or tables or whatever conversation pieces they might be, or they just get sent back to the company, depending on the company or the insurance that you have. But really, for some people, treatment of CPAP has actually improved severity of cough. Hasn't totally gotten rid of it. Part of that also is, again, we're dealing with receptors, we're dealing with stretching those receptors and stimulating those receptors. And I've got a diagram about how this all interacts in my next slide. We don't know why sleep apnea is associated with cough precisely, but that's sort of one of the theories, that the change in pressure in the lung with going up and down, keeping it constant, is one of the things that may help with the CPAP machine. There are patients who smoke. It's interestingly enough, patients who IPF that were smokers tend to have less of a cough than patients who have IPF who were never smokers. Not clear why. It's thought maybe the history of cigarette smoking may have desensitized those receptors, so they're not as responsive to other triggers going on. Definitely got to look at the medications, the chronic sinus. Lung cancer is an issue that people typically overlook. Our patients do get lung cancer, so we definitely need to pay attention to that possibility. Catching lung cancer early is one of those things that's potentially curative in that group of patients. Infection, I sort of mentioned that before, that MAI, the chronic infection. It's a low group, but this is something that definitely, if present and treated, can absolutely help with a chronic cough. Patients with MAI or MAC may just have cough. They may have no other symptoms other than cough, may not feel bad at all, or may attribute all their feeling to their ILD. So to the question that I just had, it's a matter of doing your due diligence and making sure you've cleared this list before I'm going to sit on the table and say, okay, it's only ILD and nothing else, because we see a lot of these coughs, a lot of these influencing the IPF patients. And you can see in these numbers, there's a good percentage, particularly with the sleep apnea and the GERD, and if you have a history of emphysema, being in patients with IPF.